good afternoon, everybody, and thank you for joining us. You've landed at the CAHF COVID Monthly Roundup. My name is Jason Belton. I'm the Director of Emergency Preparedness with CAHF, and joining me today is Patty Owens, Director of Regulatory Affairs for CAHF. It is August 27th, 2021, and the information given during this webinar will be up to date as of that date. We don't know what's going to come out tomorrow or later today. Sorry for the delay there. And as always, the coronavirus resources that we have developed are housed on the CAHF.org /resources/coronavirus. And that'll be important as we talk about some of the templates that we're going to put on the website here very soon. So we'll get to that in a second, but that'll be where you'll be able to find that information. All right. As a general housekeeping and traditional, a standard introduction to these webinars, the speakers' opinions on the webinars are their own, and they may not reflect CAHF's official position. In instances where CAHF has an official position, I'll definitely mention that. These webinars are brought to you as a part of a grant-funded program with CDPH and Los Angeles County EMS agency. And I have no financial conflicts, and nor does Patty, and we'll be the only two speakers on this webinar. In terms of the intent of the webinars is to give you a situational report with things that have changed. And I realize since we've converted to a monthly format, a lot of this may be repetitive with what you already know, and if anything, it'll be just for you to confirm that you have all the most up-to-date information. So if you're regular attendees to lots of the webinars and calls, some of this may not be groundbreaking to you, but we'll try to kind of crystallize everything so you know where it changed from the previous versions of the AFLs. We'll do some forecasting where we can, especially as it relates to staffing, and highlight best practices where we can. So that being said, let's get started with our program, and we'll talk about the AFLs first. And I just want to highlight in the handouts for today's AFL are 3 separate documents that are called red line changes. And Patty and her staff put this together, and it's really very helpful. And I think as you do your, kind of change your plans, that you have written plans, it's helpful to use these red line versions, because then you can quickly identify where in your plan, it needs to line up with what changed in the AFL, and it gives you a visual indicator of where the differences are, so you can at least more quickly or more effectively change your plans. So hopefully those are helpful to you. I've included red line changes for the AFL 14.1, 22.9, and 53.5. And those are all, the 14.1 and 22.9 have to deal with visitors in skilled nursing facilities and intermediate care facilities. And I'll go over that now. We'll go over those changes now. So in terms of the visitor restrictions, they changed the requirement to be consistent with the state public health order, which we talked about last month. It came out right at the end of July. The revision requires the SNFs to develop and implement a process of verifying vaccination of all visitors, and that includes those, not just visitors coming to visit your residence, but we'll talk about the non-essential personnel and how they're included as visitors as well. You'll have to have a process for obtaining and tracking documentation of the test of all visitors who are unvaccinated and incompletely vaccinated to have an indoor visit. That's important to notice. That this is for indoor, not the outdoor version. In terms of the methods to verify vaccination, we discussed this already. I wanted you to have the information because I didn't put a link to the digital record on the last presentation, but wanted to make that available to you now if you didn't have that. So you can have the CDC card, the actual physical card, as long as the card's filled out and it has the the type of vaccine, the date of the last dose administered, and obviously the name of the person, and it matches with who that person is. A photo of the vaccine record card is adequate proof. A photo stored as like a PDF or a separate document would be okay as well. Documentation of vaccination from another healthcare provider is okay. The digital record with that QR code is okay to be used. If you do use the the digital record through the QR code, the recommendation is to have a QR reader or have somebody with a QR reader on their phone that can take a picture of the QR code and make sure it pops up with the information from the vaccine. And it will have that information that, the same as it would if they had a physical card. Now, if you have employees that are shared between different buildings, they work in one building part of the week and work in another building a part of the week, it does, as long as the one of you shares information with the other of you and you both have the vaccine records for that employee, that's fine. In the and this is really important because CDPH has said this, and this is pretty consistent with how they kind of do things when there's legal questions about the types of documentation. This is very common that they say, here are the real basic things that you have to meet. As long as you meet that, the content of the information is going to be, you don't have to necessarily view this like, if it's clearly fraudulent, you can't accept a record. But if it's fraudulent, and it appears legitimate, then you have done your job, and CDPH is going to be okay with that. Now, besides the fact that as long as you don't know it's fake, then you may accept the documentation as valid. Facilities also are going to have a plan in place for tracking verified worker vaccination status, and that for your normal run-of-the-mill employees, that should be fairly straightforward. For keeping records of the non-essential or contractors or things like that, those they basically said for anybody coming into the building, visitors, those non-essential personnel, contractors, any of the visitors that are coming into the building, you'll need to keep documentation for at least 1 year after the end of the public health emergency. So you're going to have to keep documentation of all of that. And obviously CDPH and the local health department will need to obtain or have access to those records. In terms of the indoor requirements now, the requirement is to verify the vaccination status of every person coming into the building, and or document. And for those that are seeking indoor visits with their loved ones, they need to document a negative test within 72 hours of the visit. Now, the type of test that they can use to access come into the facility is either PCR or antigen. If they're using an antigen device or you're using an antigen device, the best practice would be to have that antigen test drawn 24 hours prior to the visit. Now, I don't know that language actually was added into the AFL, but I did hear Dr. Epson say that. And I think based on what we know about the performance of the antigen testing devices, I think that would be a very reasonable thing to say. You're going to use antigen, do it within 24 hours of the visit. We're assuming if you're using antigen, it's through the use of the POC device, and you're going to be doing it probably at the time of the visit. But in other cases, especially in the cases of home tests being used by the visitors, now, in the AFL, it did talk about the home test being allowed to be used by the visitors. It did have that same requirement that essentially, if a home test is used, you have to be, somebody from the facility has to physically watch the test be used to make sure that it's done in the correct manner it's supposed to be done. And so I don't know if you guys have seen the the home tests from Abbott, but the Abbott home tests look very, very similar to the tests that we get in the antigen testing packets when we get them from the state. So I don't know that the tests themselves are that much different. If you're used to working with the POC antigen device and somebody brings in a home test kit from Abbott, in the AFL it talks about how it can be used, but you must witness the actual test to make sure that it's collected appropriately. Everyone in the facility needs to wear a well-fitting face mask at all times. If both the visitor and the resident are fully vaccinated, then physical distancing is not required. So that means they can have an indoor visit, they can touch, they can hold hands, they can hug, but the mask stays on for the duration of the visit. There are one small exception to that, but for the most part, masks stay on, and they stay physically distanced from anybody else that's visiting that's not a part of their group. If either resident or visitor is not fully vaccinated or partially vaccinated, whatever, they need to be 6 foot physically distanced during their visit, as well as obviously keep the mask on for the entirety of the visit. Now, if either one of those folks is unvaccinated or partially vaccinated, then they cannot remove the mask, and we really should discourage them from planning to have food or drink during their visit, because we're going to ask that they keep their mask on. It doesn't matter. So, but if both of the folks are fully vaccinated, then the resident and visitor could remove their mask to eat or drink, but just for those activities alone. And then they would have to put the mask back on. So it's a little bit different than what we had previously been doing. Now, so the changes for outdoor visitation, fully vaccinated visitors may conduct their visit outside without masks or social distancing. And that does include physical contact, hand holding, hugging, that type of thing. For non-fully vaccinated folks, and either the resident or the staff member, visitor, then masks and distancing, even outside, have to stay in place. Now, they don't have to do the negative test within 7 days or proof of vaccination status, but they're not going to be able to do indoor visits, outdoor only for those folks, unless they test, and then they can do the test to do the indoor visit. And then they have all the other restrictions. In terms of the return to the facility, there were some slight changes. They did not really change the fully vaccinated recommendations. So fully vaccinated folks do not need to quarantine or test upon return. They could go right into the green zone. Not fully vaccinated folks need to test 5 to 7 days after the return for less than 2 hours or 24 hours. So if they go out, they're not fully vaccinated, they go out on a day pass, or they go for therapy or something else of that nature, and they come back, the expectation is you will test them 5 to 7 days after their return to essentially get a snapshot of what happened during that time that they spent out of the facility. And anything over 14 hours is going to automatically put them into quarantine in the yellow zone, and they needed to be tested prior to their return to the green zone. So that's quite a bit different than what it was previously. And then I wanted to talk about the non-essential personnel and contractors. The information from CDPH is to treat them just like their visitors. So they would be required to do the same symptom screening, follow the same infection prevention and control requirements of all the other visitors. They would be asked their vaccination status and document proof of that if they're vaccinated. If they're not, then we would need to test them or make sure that they were tested 72 hours prior to entry if they're tested with the PCR. They need to be masked the entire time they're in the facility. And when we say mask, that's a well-fitting surgical mask. That's what they want at a minimum. And the 6 foot distance needs to be applied. Now, if they're a barber or a hairdresser or something like that that's coming in, obviously the 6 foot distance is impossible to do. And there's going to be instances where contractors need to be within that 6 foot distance. the goal is to try to minimize or limit the amount of time they're within a 6-foot distance of any staff or a resident member if they don't have to be. All right, so let's move on to the changes in the testing AFL, and we've now got multiple testing AFLs, and I'll try to kind of give you what this AFL deals with, and then where the other AFL is, and we'll get to what that AFL says in a second. So this is updated testing guidance for the screening and response testing, as well as information on what to do for actions to take in the event of response testing. So it's tied to another testing AFL. It's for SNFs, it's AFL 21-28, and for ICFs, I think it's 21-30. But we'll go over that in a second. Now, the AFL that I mentioned before and I went through, I just want folks to know that applies to both ICFs and SNFs. And so the language is virtually identical between the two AFLs, or very, very similar. So the things that I have pointed out are differences on both SNF and ICF, and the same with the AFLs on the testing for unvaccinated healthcare workers. They're virtually the same, they're just written for different sectors. The good news is if your facility is above 70%, that should say vaccinated residents, then you can stop the routine screening of vaccinated staff if you're above the 70% threshold with residents. They removed that 70% threshold from the language on the testing for staff, because now all unvaccinated staff are going to have to get tested twice a week. This is just when you stop testing vaccinated staff. So if we're going to assume everybody's going to be above 70%. So generally, you're not going to be doing routine screening testing of vaccinated staff if your resident population is above 70%. If your residents are still below 70%, then your vaccinated staff are going to have to be included in your testing pool. In terms of adding language for what to do with fully vaccinated residents who test positive and remain asymptomatic, that has changed. So the new information is, even if they're fully vaccinated, if they test positive as a part of response testing, you develop, or you get a positive case and they have no symptoms, they still need to be isolated and observed for symptom development. And in order to remove them from isolation, you should consult with the local health department on the duration of that isolation. Sorry, I put duration in there twice, I don't know why. But anyways, confer with the local health department on when it's appropriate to remove that person from isolation. I think we might have differences of opinion within local health jurisdictions, but definitely the AFL does call for coordination with the local health department to determine when we're going to pull that person out of the isolation. All right. In terms of response testing, everybody gets tested, even if folks have been vaccinated. I think we all know this, but if you're in response testing, the goal of the response testing is to determine the scope of the outbreak. So fully tested vaccinated workers who do test positive should still be excluded from work. There are some allowances for staffing shortages, and we know virtually everybody is in that position. So we'll talk about that in a second. But in order, in the AFL points folks to conferring with the local health department on when the appropriate return to work for that individual employee should be. It does go on to say right after that in the AFL that CDC does have kind of a decision-making tree for what you can do in the case of staffing shortages. In the instances of staffing shortages, the CDC has requirement or has kind of guidance for how and where these folks should work and who they can work with. So there are heavy restrictions on that, but if you talk to your local health department, you go, like, I've got this person, I've got an outbreak, I've got 6 COVID positive residents, and I have 3 COVID positive staff. these staff are all asymptomatic and they're willing to work. Can they come work the red zone only because I need the staff? I'm in a critical staffing shortage. And so that's the language you want to give to the health department. You want to say, I'm in a critical staffing shortage and I need the flexibility to get them to return to work. The point of, but once they do come back, just know that there's heavy restrictions on where and who they can work with. They have to be completely separate. They can't cross over zones. They have to stay in the red zone, separate ingress and egress, separate break rooms, all that stuff. I think that's, you kind of understand that from previously in the response, but definitely that has not changed. Any new admits or readmits who are fully vaccinated without a prolonged close contact, and they define that in the AFL as exposure greater than 15 minutes over a 24-hour period with somebody that was positive. As long as they haven't met that criteria, they no longer need to test or quarantine. But I've talked to a number of folks, and folks have said, you know, maybe I'm not convinced that the folks coming from my hospital system, even fully vaccinated, are not being tested, or I'm concerned that they're going to come with COVID, and I'm just not going to have an idea what to do. So in that case, CDPH has said a more conservative approach is okay. So if you said for all the new admits, I'm going to, even if they're fully vaccinated, I'm going to monitor them for symptom development for a few days, or I'm going to test them at the door, wait for the results of that test before I put them into the green zone, or something like that. All of those are okay. You just can't do, less than what they're saying. But since this approach basically allows free reign into the green zone, I know a bunch of you have had concerns of we've already popped the case from somebody coming from a hospital, didn't have symptoms and tested negative. So I understand if you have a more conservative approach to this. All right, in terms of the testing, vaccine verification, and PPE requirements, the AFLs are 2128, 2130, that's SNFs and ICFs. This goes on to explain that, and we don't know how long this is going to last. It could last for quite a while. But healthcare professionals who are not fully vaccinated have to test twice a week. For those that work less than full time, they still need 2 tests. In other words, let's say you have somebody work in your building 2 days a week. They would need to test prior to each one of those days before they showed up. And that's from CDPH, and I know that that's not an easy or workable solution. It's not super easy if you're not doing the point of care tests, and even the point of care tests take time, and you got to do the reporting. For those working 1 day a week, the recommendation is to test before the shift, 48 hours greater or less than a shift. And it does say that's the case for the POC devices as well. If you're doing a POC device, and the person works 1 day a week, or they're an on-call or an ad hoc person, the point of care test is going to be your way around that, I think. Now we can't, just so you know, we cannot purchase the home test kits. If somebody shows up with a home test kit and they're a visitor and they want to use that as their test, there's allowances for that in the AFL, but we can't be providing them with home test kits. So don't go out and buy a bunch of these, Abbott home test kits. Try to order the test kits through the state lab. Try to order them through the MOAC. We've heard there's a backlog of these requests, but really keep putting in requests and request as many as you can. You're going to need these for a while. I really feel strongly we're going to have to test for a while. So it's worth your while to invest in those. And they have, and there's some suppliers out there that also have these. And by the way, the Abbott Binax now that we get is less expensive than the home kits. And I know that because I purchased a bunch of the home kits for my son. So they're way less expensive if we buy them on our own through the suppliers. So my suggestion, don't try to use the home test kits. For home healthcare professionals who are not fully vaccinated, if they don't work in areas where care is provided to patients, that's we can kind of get our head around that. That's pretty easy. But where the patients have access to for any purpose is a little more broad. And certainly, I've been in a number of facilities, and I've seen, I've seen places which would conceivably have resident access all over the building. I don't know if I've seen many facilities that have areas of the building that residents do not have access to for any purpose. But if you have sections of your campus or your building where residents don't have access to for any purpose, and the staff stay in that area, they don't have to do the kind of vaccine verification kind of requirement, but they still have to undergo weekly testing. So that's important to note. Just because they don't have to do the other stuff, they still have to do weekly testing. Facilities must, and whenever we see the word must, and we know that's a requirement, facilities must provide respirators and N95s to all unvaccinated or workers who work in indoor work settings where care is provided to patients or residents, or to which patients or residents have access for any purpose. Now, that doesn't mean that the employee necessarily needs to wear the respirator, although you can make that certainly a company policy. You can make it that folks have to wear respirators for source control, but that's not necessary. What's required is that you provide the mask, and then if they're not going to wear that mask, you have to provide a surgical mask. But one of the two, you're going to have to provide them with the mask. If these folks are not a part of your fit testing program, then you're going to have to demonstrate to those staff, have your IPs demonstrate to the staff how to don and doff and how to get a seal check. The CDC has a seal check video as a part of their Project First Line. I like to use that. It's real basic. It only takes a few minutes, and it gives folks the and it's geared towards frontline care workers. So it's supposed to be a layperson's understanding of how to don and doff as well as a seal check. Now, your care staff are probably they're experts on donning and doffing now, but the other folks that are not used to wearing a respirator in the course of their daily duties, you'll definitely have to at least coach them on how to use it, how to get it on and off without contaminating themselves, and as well as making sure you get the seal. The seal is a really important part of the respirator, because if you don't get that seal, where your air blows out and where the air you breathe in does not go through that filter material. It seeps through the cracks because the filter material is so thick. So make sure that folks can get that seal. And there's great videos. I just wanted to mention this because when I put that video in there, I realized that the CDC had recorded a ton of training videos for their Project First Line. And if you didn't have your staff attend, or they were unable to access that Project First Line, many of the training videos are housed in that playlist that I link right there on the bottom. And it's a lengthy list. There's like 30 small short videos designed just for frontline care staff. So it's a great resource that I didn't know until I found this video here. So. All right, let's just talk for a second about the state public health orders. The state public health orders linked here. They also came out with some FAQs for the health orders, and I just wanted to give folks, access to where you can find the FAQs besides just the health order. All right, let's talk about exemptions. I'll start with talking about managing the exemptions for religious purposes. CAHF has developed 4 templates, 2 templates for the religious exemptions and 2 templates for the medical exemptions. Our drafts are done. We're submitting those to CDPH. We realize we're fairly realistic that CDPH is not necessarily going to bless our template, but more importantly, we want them to at least review the template to make sure it's consistent with what they expect facilities to have for documentation. And provided they get that, and I think that's the best we're going to get from them, is to say, yes, this template will work. We can't say it's good or bad, but we wouldn't cite a facility for using this template. And I think that's probably the best we're likely to get out of them. When that happens, we will post the exemptions to the CAHF website. And I do know how it's going to, really what it's going to break down. There's going to be a more in-depth version of each one of the exemption forms. So for religious exemptions, we're talking about two different forms. One form that's going to be basic, that's going to have folks talk about, it's always going to capture the employee information, but it will require less work on the facilities part to review the documentation provided by the employee. And then we have another form that's a little more in depth for those of you that want to explore the tenets of folks' individual religions to make sure it's consistent and it does not appear to be fraudulent or something that's a moral opposition to the vaccine or a political opposition to the vaccine versus a true religious belief or a sincerely held religious belief. I realize that not all of you are going to fall under one category, so we wanted to give you guys options for both. Those will be, the drafts are done. They'll be up on the website very soon. We do know that CDPH, even if you choose to do your own, which is fine because there's tons of exemption, you just Google, I mean, you can find a million of them. I took one from University of New Mexico and I redid that one. It took me 30 minutes to redo it. That's not the one we're going to use, but my point in saying that is that with a little bit of work, I think it's pretty easy for you to just remove the references to the other company that produced the template and put in your own letterhead, remove references to certain things and go with that. You certainly can do that. My real honest opinion, the opinion of our general counsel would be that if you're going to do that, please, confer with your labor and employment counsel so you can get an idea of, is this going to get me in trouble or put me at risk, especially when it comes to exploring, this someone's religion. You can worry about, did you do it equitably and fairly, and did you treat everybody the same? And so when you have folks sign those documentations, you want to make sure your counsel will make sure that that it's not going to put you at risk for a lawsuit. Consequently, you can also wait for, my hope is by the middle of next week we will have them up on the website. So now CDPH is not going to verify accuracy of the, well, they'll verify accuracy of the documentation, but maybe not the content of the documentation. So they're not going to say, oh, hey, this religion doesn't have that tenet. This is not an appropriate exemption. They're not going to look at it like that. They're going to say this person acknowledges they need the exemption for their religion. It clearly states who they are, the facility they work for, that they signed it, and that's really all CDPH is looking at. Now, what CMS says when they come out, we'll find that out, but we just know they're going to be very basic on what they're looking for because they don't want to put themselves in the crosshairs of discriminating against people's individual religions as well. So examples show varying degrees of questions that folks will ask about religious beliefs and where in their religious beliefs does it describe the requirement to decline vaccination or maybe the specific vaccination. I've seen some letters from Catholic clergy people that are not from necessarily the Catholic Church in general, but from a group, from one Catholic church that mention specific things. So there's going to be, folks in the clergy are prepared, if that's a part of their religious tenets, to be able to give supporting documentation to the folks in their congregation to be able to say, here you go, this is what you need. And so we can expect that those folks will be able to provide that documentation if it is appropriate. There's no right way from a survey perspective as to how this is going to be done, but like I mentioned before, if you decide on your own to do your own, run it by counsel first. And CMS will be releasing the rule for the Biden-Harris requirement. If you've not heard, hopefully I'm not breaking this news to you. It's really immaterial here, in so much as we have a state health order to do the same thing. But the federal government has basically said everybody that works in long-term care, skilled nursing facilities, and intermediate care facilities is going to be required to get vaccinated. And we anticipate there will be at some point an F-tag, whether in an existing F-tag or a new F-tag, that will potentially cite scope and severity for you not making sure that everybody in your building has been vaccinated and or they have a legitimate exemption. We don't think the exemptions are going to change. We think the exemptions are going to stay consistent, having a medical exemption and a religious exemption, but we don't know that for sure, but we're pretty confident. All right, I want to hop on to the medical exemptions, because the medical exemptions has a little bit more of a definition here as to what qualifies for reasons why you should not get vaccines. And in the first link there that you see, that links to the clinical considerations that shows all of the kind of pre-existing conditions you should think of, or that doctors need to think of before they recommend to their patient to get vaccinated. So, but similar to the CDPH decision on the religious exemption, the note from the MD or the doctor only needs to state the medical exemption exists and the duration for how long the accommodation is needed. So it doesn't necessarily, from CDPH's side, it doesn't necessarily need to state what it is they're seeking, what medical reason the exemption is needed. That does not need to apply on there. But if we're going to, like I said, we're going to do a couple of different templates for the medical exemptions, and one is going to require more documentation and will really allow you to explore the reasons that the medical doctor is giving for the medical exemption, as well as one that's a little more generic that allows the doctor to make the decision and you to just verify that it is a physician, a licensed physician making that decision, and you're putting that into action. Now, these things have changed a little bit, but I don't anticipate the clinical considerations to change. So if you do have a template form that has more detailed information about what are appropriate medical exemptions according to the CDC, just make sure that if you have that form in there, that you have some process to monitor. If those clinical considerations change, then you'll have to make that change to this document too. To the exemption document, if you have onboard new staff, you just have to make sure to, if you link one to the other, you have to have a process to catch that on the back end if one needs to change. And then of course, documentation is going to need to be kept and made available to CDPH. All right, and I think I repeated this slide, but I wanted to list the toolkit on the bottom here. And so this is a toolkit that HSAG passed out on their webinar. It's to the SHAE, S-H-A-E, I think it is. I forget the acronym of what it stands for. But if you click that link, it's a number of free resources about, and you can see some of the other example exemption letters for a University of North Carolina, Duke University. I think there's a few others in there. It has a checklist, a really good checklist on what to do, getting prepared for medical and religious exemptions, and all the things that you need to think of when you're talking to your employees. So I thought that checklist in and of itself was worthy of the link. The example exemption letters that you can look at from those other entities are probably a little overkill for us, and they would require quite a bit of editing to remove all the references to students and other things like that. But they're a good indication of the kind of questions that are going to be asked across the board from employers of all different types of folks that have either an employee mandate or a government mandate for their industry. I think this is, we're a little concerned about this, and we're a little fearful of our where we, what our liability exposure is for getting folks to sign this. The reality is, I think this is going to be the rule of law, and we've got a lot of precedent for this in the flu, mandating flu and other things. I just think this is going to be the norm for folks, and for a lot of folks in a lot of different industries, not just healthcare. All right, so there were a few other AFLs that came out. I did not feel like we would have time to talk about them, or that they really rose to a crucial level, but I'll just say that AFL 2132 came out. This is healthcare facility certification correspondence, saying that it's going to come out electronically. The AFLs all come out electronically. You need to update your information at that link to be able to make sure that you're getting all of the appropriate facility certification information. If you've not updated it this year, please go in and do it for this year. Or if you're new to your position, or if your position is switched, go in and do that. And that the same thing goes with the emergency contact information. Please enter all that information in. I spent 3 hours yesterday trying to find locations for people evacuating out of skilled nursing facilities in Tuolumne County. I can't tell you how difficult it is when the information is not updated in the database. If I go to call you in an emergency and the administrator from 5 times ago is still listed as the emergency contact, it doesn't help at all. It actually takes away from my time to help other facilities, because I have to spend time to cross every base, and it's just time consuming. So it helps if you can update it. I know you guys don't see it on the back end because you're like, I never do that. But for us on the emergency side, when we need to get a hold of you right away, it's critical to have up-to-date information. In terms of the state public health order, or the governor's orders, those were extended until 12/21, and that happened while I was on vacation. I apologize. I should have sent out a forum announcement for that. It took me a week or two to catch up to that. But that's linked on the bottom there if you have questions. But it is extending the health orders that were already in effect. All right, let's finish up with a couple things. One, staffing issues. And I just want you to know, if you are in one part of the state and you're feeling this acute problem with staffing, just know that issue that you're feeling is felt universally across all 58 counties right now. Everybody is hurting. Hospitals, EMS providers, particularly. It's really dire right now. So sadly, the registry is still the primary and virtually the only option right now. The MOACs, and I listen to, it's not in my position to really contradict Cassie on the calls, and I try to play nice as best I can, but the MOACs have no staff, or at least not staff to spare. If evacuation is imminent, you have a large outbreak and you're missing a large number of staff, and the only option is evacuation to a hospital or another nursing home, or them to bring staff. In those instances, they might be able to get you staff. But in terms of staff that need to be there long term, it is not a realistic option. I want you to really double down on registry. Sadly, it sucks so bad. I hate to say that, but it's just that there's nobody out there. There are abilities, I think, to get creative. We've got to talk about sharing staff. If you're a corporate entity, you're going to have to look at sharing staff internally. And I know that's really frowned upon in the COVID environment, but we're getting desperate now, and there's nobody else out there to come help. So we need to explore other manners for getting staff in there. if at all possible. And even if that means sharing staff across agencies or across entities when needed, I think we really have to look at doing that.
Jason, could I jump in real quick?
Absolutely.
All right. Hi, everyone. It's Patty with CAHF. I just wanted to go back on the last topic on the executive order that did come out earlier in the week, and make sure everyone's aware that there's certain, they've extended certain workforce type executive orders, and some of those have been removed by CDPH already. And so we did reach out to CDPH, and they are revising AFLs regarding the newest executive order that's going to extend certain waivers specifically towards workforce. And so we have reached out. We expect some space conversion, CNA requirements, stuff like that to come out sometime. Some may drop today, but we expect probably by middle of next week.
Yeah, and that's a great point. And I know we've talked to folks about filling out a 5000A and having that downloading the template version, having it filled out and ready to go. Even if you're not in a staffing crisis now, I mean, it might be worth 10 minutes to sit down and make sure that you got it filled out, you understand where it needs to go and who it needs to go to. And that way, if you run into an emergent situation or a dire situation, you can get that 5000A off the CDPH quickly. Now, I heard
well, our concern though, Jason, with that is that the newest executive order eliminated again that process. So we're not really sure how many of those CDPH is going to actually approve. Of course, it's worth to show your good faith efforts of submitting your temporary program flex for your staffing needs, because it is a good way to show all your good faith efforts to try to be in compliance and to meet your staffing needs. But right now, we're not quite sure how CDPH is going to put out regarding this newest executive order, where they specifically stated the agency wasn't allowed to do anything regarding additional staffing waivers other than what's already in current law, which would be the workforce shortage waivers and the patient needs waivers. So we have that on the table right now.
Yeah, and our hope is we get that extended out. And based on what we've seen and the dire need across the state, I'm hopeful that we can at least get that process reversed. So, I just wanted to mention, if you call the MOAC or you go through the Salesforce process to request resources, I know most of you have, if you've requested staff, you've already probably gotten a call from your MOAC and said, okay, here's a list of registries. You go call them first. Once you've expired that, then call me back. And generally, that's going to happen across the state. So if you think you're going to have a need, for staffing, the MOAC's expectation is that you will have already expired or exhausted all of those other resources for staff first. So just make sure that before you even go through that process, make sure you do that first. And that way you have proof and you can say, hey, look, I've called X, Y, and Z, and these are the folks that I have, available, and they can't meet my needs for, this shift, that shift, and this shift. And then you can talk to them about, can I get somebody I need a CNA for this shift, I need an RN for this shift, I need an LVN for this shift. Whatever the case is, be specific about their request. The facility's responsibility really is to ensure safe care to the existing residents first. So we've had a lot of discussions about this, and I think it's completely appropriate, because right now you're kind of in between two places. You're forced to take admissions from the hospitals, even COVID positive folks, regardless of your ability to staff. Yet if you take those folks, you're going to be at risk for citation for not meeting the 3.5 or 2.4, or not being able to dedicate staff to a red zone. In those instances, I think it's completely appropriate to say, look, we can't take new admissions until we can safely staff it under these conditions. Now, not everybody's having that same staffing problem, but I think that's appropriate, and we know a number of you are doing that and following suit. It is going to drive the hospitals bananas, and I don't know what else to do, but you can't create an unsafe condition. And I think if you made that decision and say, look, I'm not going to take a deficiency for 3.5, 2.4 because it puts me in an unsafe condition. So I'm just not going to accept any admissions until I have enough staff to deal with those admits. CMS or CAHF is advocating for reinstatement of the blanket staffing waiver. Well, we just mentioned that. We're also asking for 3.5 and 2.4 to be waived, but we've been asking for that for a year. I don't know how successful we'll be. The problem is worse now than it was at the beginning of the pandemic. And just for context, across the country, we've lost approximately 380,000 employees in just long-term care due to the pandemic. So that's not, that's a lot of people. That's over 10% of our workforce is gone.
And Jason, also I wanted to bring up the fact that, for the CNA testing sites, the American Red Cross is pulling out of California and also other states on doing the testing for CNAs. So California currently will be down to only one approved vendor in California to test CNAs, and that will go into effect in October. And so if anyone is out there on the call, or spread the word, if you're testing any of your CNAs, because the testing dates are 2 months out. So if you have students testing with the American Red Cross, or you plan to, try to get their testing done as sooner than later, just in case they have to go back and retest. Now, the other vendor in California, their tests are in their curriculum is a little bit different than the American Red Cross. And CAHF was on a phone call today with CDPH and the other California provider of the testing, and they're going to send out, and they have available, and it's free, like crosswalk material that will help if you are going to have to switch your CNAs to test over to the other testing vendor once American Red Cross comes out, but yet they completed the American Red Cross curriculum that you were using. Anyway, so that's going to be a challenge coming up in October that as they estimate, it's about 1/3 of total tests taken in California are from the American Red Cross. The other vendor does feel like they will be able to absorb most of that 1/3. However, they're concerned about, the pass rate for those CNAs switching to test with them. So there's a little update on that. If you have more questions, Claire Enright with CAHF is working on that currently and would be happy to answer any of your questions.
Awesome. Thank you, Patty. And so I just want to talk for a second, and I'll try to get to questions in a second here. So the third shot of the mRNA vaccines have been approved for immunocompromised folks. CDC is recommending now that moderately to severely immunocompromised people can receive an additional dose, and those people include those folks on the list. That's all that's on the list. Nothing else is on the list. So if they don't fit on that list, it's not a part of the folks in the CDC recommendations. Now that's different than booster shots. Well, booster shots are coming. We do know that the FDA is encouraging booster shots. What I want you guys to do is, we don't know, we're kind of waiting on some feedback from CDPH when we should start, some guidance on when we should start doing that. But we're pretty darn close to the 8-month kind of metric that they're setting for a lot of our residents and staff. So I don't know if the booster shots are going to be recommended for everybody, but definitely for our residents. If they're going to be recommended for anybody, it's definitely going to be for them. And now we went through the pharmacy program, and most of you, I'm not going to say all of you, but 70% of you probably did not have the ability to do vaccines yourself. And so for you guys, you're going to really have to explore those options with your long-term care pharmacy about what is their ability to access those vaccines, what is their ability to support shipment of the vaccines or administration of the vaccine or any of those things. You'll definitely need to confirm with them about that prior to that. As of now, they're the folks that CDPH expects us to gather our or to get our medications through the long-term care pharmacies. The expectation is not that they would revisit like a clinic or something like that, where they would come out to a facility and do everybody at once. There's no talk of that I'm aware of to do that. So the expectation is that you're going to contract with your long-term care pharmacy to inquire about those and to get the appropriate medication. In Los Angeles County, it's a little bit different because you do have the opportunity to order. If you were a part of the program in LA, you can order your own supply and do the administration of your own vaccine. I would work with your medical directors and essentially develop a plan for when you want to start doing the boosters. Obviously, take a look at if you have immunocompromised folks in the building, getting them shot. There's a lot of other talks about, mixing the doses and things of that nature. To the extent possible, CAHF is not ever going to recommend that you interchange these medications. We think they were designed to work with their own. We realize there may be some benefit, maybe even an equivalence to the traditional method, but we can't recommend that you would mix and match. So try to keep the medication consistent with the medication that they received the first time out. So I just wanted to mention that. All right, I'll try to hop to questions now here. We only got a few minutes left. Holy cow. Oh, we got a few and long ones too. Oh my goodness. Is there a link to the website? They were able to look up the vaccine info. Yes, that was linked on one of the slides. It's digital vaccine record. If you looked at the digital vaccine record, Google it, it should show it up. But okay, here's a good tip for us, because apparently the vaccination digital record may not populate for nursing home residents or staff because the pharmacies did not appropriately collect or enter mobile phone numbers or emails. If the phone or email is updated on Care 2, then the QR generator site will do that. And based on the, I think it's easy to kind of assume based on the amount of vaccines that they were doing at that given time, that you can totally see that probably lots and lots of people are not going to be able to access their vaccine digital record because it wasn't appropriately entered into the system it needs to be. I'll just say that there are other options besides the vaccine digital record: a physical copy, a copy of the medical record, a picture. There's a lot there. If you have one-offs and things like that, if this is something that occurs frequently, let me know, and maybe we can work with CDPH about a workaround for that. If all of those methods do not result in being able to view a vaccination center. To clarify, everyone coming into the building, contract worker, plumber, infrastructure, etc., including this, and only those who are, yes. So for the visitor requirement for indoors, that includes those contractors, plumbers, anybody that's coming in to the building. They're expected to have proof of vaccination. If they're fully vaccinated, they can come in. Obviously, they need to wear a mask, or they need to have that negative test within 72 hours. And that applies to anybody coming inside the building, whether they're your employee, whether they're a contractor. Well, your employees have different requirements, but whether they're a contractor or a visitor or something else of that nature, yes, that is the new recommendation, and that's where it differs quite a bit from the previous version. So if you've got a contractor, well, let's say you got this. You got a compressor that goes out on your HVAC. It's middle of summer. It's an emergency. You need that compressor fixed, right? If that guy can do his work on the outside of the building, none of this applies. But if he has to come inside to check the registers or do anything else to verify, that person is going to have to be tested if they're not fully vaccinated. If they're fully vaccinated, great. Then you just get a copy of the vaccine card and you're good to go. If not, you're going to have to test them with a point of care test before they come in. Or have access to rapid PCR testing somewhere to get that done. But that has to happen before they come into the building. If you have something scheduled, I've got a contractor coming in on the 30th, right? I know they're coming. I say, look, are you fully vaccinated? Is this, when you talk to the company you contract with, are they vaccinated? Do they have proof of vaccination? Because I'm going to need proof of that in order for them to come do work on my building. I need proof of vaccination. If they're not vaccinated, then they need to test 72 hours prior to showing up for work on my site. And if we can't arrange the PCR testing, then we'll do the point of care testing on site. I think that's really what CDPH is looking for folks to do. Are physicians required to document that the resident is immunocompromised and eligible for the third dose? I believe so, yes. And it has to be an order from from a doctor. So yeah, I would have to list out why they're seeking the thing. Now, I don't get into why, could a doctor, make a recommendation or prescribe a third dose, regardless of whether they fit the immunocompromised criteria or not. Of course they can. Doctors prescribe stuff off-label all the time. So it could happen. The CAHF is not in the position to say that they have to do that. That is solely the medical director's responsibility. But I just want them to have the information so that they know these are the folks that constitute an immunocompromised state for the COVID vaccine. Some residents do not meet the eligibility criteria outlined by CDC, but physicians say that they are immunocompromised and gives a verbal order or a telephone order, but no actual documentation. Now, I don't know about the verbal orders or telephone orders. I might have to actually ask that question of Deanne, our clinical director. I would be uncomfortable with that. I want them to put it in writing. Oh, okay, that's fine. Can you email me that in a form rather than a verbal or telephone order? And that way you're protected to make sure that it was the medical director or that actual physician that signed off on this case. All right, that was the end of our questions. We're at 2:02 in the afternoon. I'm sorry, we are overwhelming you with just government documentation. We will be back with you next month, and then we hope to see you guys. I did not mention the CAHF annual conference, but we hope to see you guys in person in November. Our plan is still to have the conference in person. We will have a company doing vaccine verifications, and everybody will fill out a little questionnaire on their symptoms prior to showing up. There'll be a little app. We'll try to do our best as we can to protect everybody, to make sure that nobody gets sick at the conference and takes it back to their building. So we've instituted some pretty stringent IP measures for the conference, but that doesn't mean we can't hang out, learn, talk to each other. We might be able to hug outside of appropriate things. Lord knows we all need a hug every now and then during this response. So hopefully we'll get to see you all there and talk to you then. If not, I will definitely see you back here at the end of September for the next webinar. So take care, guys. Have a great weekend. We'll talk to you soon.